Good morning, everyone, and welcome to our monthly live session of peripheral interventions from Mount Sinai. I, Vishal Kapoor, would like to welcome you, and I have Dr. Atul Kukar with me here today to help us get through this case in this our February monthly broadcast session. Before we go in, just as a reminder, please log into our website, ccclivecases.org. You can go under the peripheral section tab and see all our previous cases in the archive section. You can leave comments, suggestions in the comment section, and also you can see this case by the end of the week. Sorry for the delayed start. Our Chief Operating Officer, Dr. Krishnan, has a little injury, but we're all up and running. So good morning, PK.
Hey, good morning. How are you guys? Thank you so much again for your patience, and I'd like to welcome everybody to our lab. As you know, we have our team together again. In front of me is Dr. Karthik Guja, who's our Associate Director of Endovascular Services here in Sinai. Ray Lascano, our Interventional NP, our Endovascular NP, our new Endovascular Fellow from Austria via our Interventional Fellowship Program, Dr. Serdar Farhan, forgive me. And I'm actually, a lot of NSAIDs in me right now because I've got a horrible knee injury. And I've got Elizabeth, our endovascular nurse, and Damien, our technician. So we've got a fantastic case to show you. And this is a case that really, I think, illustrates a lot of things that we talk about in terms of approach to the disease process. So I'm going to ask our fellow to go ahead and present the case. And then we're going to go ahead in the meantime, take diagnostic pictures and come back to you. Let's take a DSA shot.
Okay. So our patient is a 86-year-old female. She complains of bilateral claudication. However, right side is more than left, and she has a non-healing ulcer on the dorsum of the great toe with a Rutherford classification 5. Her past medical history includes sick sinus syndrome with status post pacemaker implantation. She has diabetes, hypertension, hyperlipidemia, and she has also an extensive peripheral artery disease with a history of a recent complex right SFA CTO intervention, which we did in January 2019. Furthermore, she has Afib, and she is on oral anticoagulation, and she has a status post CVA without residuals and asthma and hypothyroidism. Among her medications, as you can see, she is on an anticoagulant, she has an aspirin, she has her anti-diabetic medication, and a beta blocker, and some medications for her asthma, and cholesterol lowering medication with rosuvastatin. The next slide, please. So on the non-invasive imaging, vascular ultrasound, we found a right superficial femoral artery, which is patent, with a patent intervention site from last time. A mild stenosis at the level of the profunda femoris, and the iliac artery, CFA, and popliteal artery are patent. However, the below the knee situation is a little bit tough. She has zero vessel runoff with proximal AT, CTO, total occlusion of the PT and the peroneal. Next slide, please. Here are images of the last angiogram which was performed on her. As you can see in this running image, you see the popliteal artery with almost diminished on only collaterals are showing up in this image, and the second and the third still frames are showing the mid and distal portion of the AT with the dorsalis pedis artery, where we are planning to obtain our alternative access. Thank you.
So she underwent, Vishal, and Atul was with us last time. So she basically had a completely occluded SFA with no osteal, and no ostium at all of any value. So we did a direct SFA access into the occluded vessel, retrograde, came back, used ultrasound to get back into the common femoral, and then stented the SFA, which is complicated by perforation because of a heavily calcified vessel. But Atul is her primary cardiologist, and Dr. Kukar will tell you, at least he informed us, that her rest pain went away. However, she continues to have an ulcer in the foot that's non-healing. Atul, could you comment a little bit about how she did clinically after the SFA intervention?
Yeah, so for the first 2 weeks after the SFA intervention, she basically said about 80% improvement of her rest pain at night. It's a little difficult because she still has some left foot pain, but her Tylenol and her narcotic doses have been decreased substantially, and she's able to sleep a little bit. But after about 2 weeks, she started getting a little more discomfort in the foot, and we think it's more from the actual ulcer itself, which is not really healed. It's definitely not gotten worse. There is some margin improvement, but the podiatrist, who we work very closely with, also feels that there hasn't been significant improvement, and we should get a little more aggressive and kind of speed up the process.
And rightfully so. What we did was we worked with our vascular surgeon, Dr. Daniel Hahn, who all of you have met here in our live cases. And Dr. Hahn called Dr. Kukar and told him, hey guys, you need to bring him back sooner rather than later. Bring this young lady back sooner rather than later. So that's why she's back. Now, interestingly, I want to turn your attention to Dr. Gujo, who's working really hard here, because before I show you the angiogram, actually, while he's identifying what he wants to do, I want to show you the angiogram. Let me show you the angiogram. So, as you know, we got contralateral access as we normally do here at Sinai. We went up and over, and I want to just show you the iliac has no disease. Now this is the SFA intervention. Now, don't be startled by the flow. The flow is bad. That's the old, hematoma, the intramural hematoma from our difficult intervention that we had. And then you can see here the SFA is still patent, although the flow is not the best. And the reason the flow is not the best is distally, we've got still a very significant and scary occlusion of the popliteal. You can see here the popliteal is occluded, and you can see very, very slow filling. That little dripping there was not there before, so we've been able to find another island of popliteal that was not there. But if you see distal, there's actually no flow at all, or very, very little flow distal, although she's able to get into the big dorsalis pedis right there at the level and running into the, anterior tibial into the dorsalis pedis. So what I normally do here, and I think it's a good process, I know Karthik and Vishal abide by it because I think they agree with me, in the sense that when you have this kind of lesion, when you have all these unnamed collaterals filling a distal vessel, we tend to get ultrasound access to that distal vessel and just put a wire in it. Our primary goal is always to cross from above, but our secondary goal is if we fail from above, we'll go ahead and cross from below. So what Dr. Guja, now you can turn attention to Dr. Guja. Can you show them the ultrasound, Dr. Guja, just to see what you see? Very difficult, right?
Do they have access? So. Yeah, because she has so much venous outflow. Her veins are actually so large. You can clearly see there is some staining even before we inject. These are all her veins. They're huge. So even her veins are pulsatile. That's what makes it difficult. I think her artery is actually in the center. The other big one is her veins.
So you can see here, even with ultrasound guided access, it's going to be very, very difficult.
Can you go up on the gain?
Can you go up on the gain, Damien?
So that they can see.
Would color Doppler help you here at all?
So we can put color Doppler, but because the veins are so pulsatile, I think you'll still have the same effect. But Damien goes up on the.
As Damien's going to go up on the gain here. Is that good? No, nothing happened. I didn't see anything happening.
So that's
there,
perfect.
That's
okay, that's better.
That's
so you see that small vessel which is in the center.
Right. Between the two veins.
Between the two veins. So there are a lot of veins. It's not just two veins. She has a lot of veins. You can see all those compressible ones are all veins. Right. So the only one which is right in that center, which is pulsatile, small pulsatile vessel, right in the middle.
We see it.
Right in the middle. I think that's your artery, which is calcified. You can clearly see the calcification. Everything else is... Normally, every artery is accompanied by two veins. But what happens here is, I think because of her increased venous return, clearly because of the ulcer and everything, she has multiple. You can clearly see there are like six of them there. And all of them are compressible, except that small vessel in the middle, which is just pulsatiling right there.
Yep.
So that's our vessel to get.
So what needle do you use? What do you like to do? What's your normal?
So we use a small radial access needle.
Get a radial access needle, guys.
And there's a pedal access kit. Cook has it. I think Terumo has it now too. But you can use any of the access kits, or you can use a radial needle too.
Okay, so what we're going to do is we're going to get in with the radial access needle, and obviously I'm good at angiographic access. So what we'll do is Dr. Guja, I think, is doing the right thing here, is to use ultrasound to go ahead and get access. Obviously, with all these veins, it's likely you may get into a vein either way, with angiogram or with ultrasound. So what we're going to do is we're going to get access here and just leave a wire. So our anticoagulation right now is angiomax, and then we're going to come from above with a curved catheter like an aqua tempo, and then we're going to start working from above and below. So I think, in my opinion, if I'm a betting man, I think we're going to cross from below, but I think it's worthwhile to come from above and below. And our algorithm is going to be to, once we get in, is to put, check our ACT, make sure our ACT, the angiomax is in the body, and once the angiomax is in the body, we're going to go ahead and float a 014 wire over an 018 Trailblazer into the anterior tibial artery. Once we get into the anterior tibial artery, what we're going to do is we're going to leave it there, try to work from above, and try to meet our wire, and then have a target to go to. You need a longer one?
No, I think the problem mainly here will be not to get into any of the veins. So that's probably the most highest, as PK was saying, because there's so much venous return. The highest chance is to get into a vein first. But again, that's what we are trying to avoid with ultrasound. So we want to go across all the veins, not to get into any of the veins.
You can see the needle denting all the structures there.
I think it's a little bit
And
more
Ray's
medial
watching
it's
for
going.
flashback. And then as soon as we get in, we'll be able to see where we are. This is obviously a very difficult access. Got it? Got something.
Yeah, I guess
That looks like artery.
yeah, it's
So
it's
we're just gonna watch this on ultrasound. Karthik and Vishal both are incredibly proficient at ultrasound. You want to do a little fluoro or no?
No, I think.
Is it going?
Yeah, I mean, Karthik is right. It's technically
Yep.
challenging because
Right.
you have really no
You wanna go
inflows.
lateral
Even
just
the
to show them on
artery
this so they
becomes
can see the artery,
compressible.
or-
So
Yeah.
I think that's the issue
longitudinal.
here.
So you remember the probe we use is a hockey stick probe, and you can see here he's got access. It's very difficult, guys. So you can see I'm just going to do twirling of this to see whether we get any reverberation. Huh? There it is, right there. I see it. Right. Let's see. Any resistance? We can see. Let's
See?
floor. Ready? Floor.
It's hard to know based
It's
on
hard
the
to
vein.
know.
And also,
Whoops. So I move this down. I don't know why it's not
Yeah.
moving now. Yeah, it looks good right there. Push it
off
slowly
a
up.
little bit.
No, you're gonna have to take a picture. Ready? Just sitting. Sitting would be better.
So
Ready? So
looks
we're
like
just gonna
we
cine.
looks like we're
Looks-
definite.
Looks good to me, but you know, who am I to tell? This is the proof's in the pudding now.
Because there's so many veins, it's hard to say
Yeah, and
exactly where we
Yep.
are. I think we are in.
You're certainly good.
Yeah, we are definitely.
All right, so what we're gonna do here is we're gonna go ahead and put the dilator in. Let's put the dilator in, Guj. Oh no, don't push.
No, I'm not pushing. I
yeah.
just keep getting a
Just
secure
put the
position.
dilator in right now. And what we're gonna do is we're gonna give our radial cocktail. So let's give the cocktail. Dr. Sardar is gonna go ahead and get the cocktail. There's a dilator right there in front of you.
So as PK was talking, I was just trying to concentrate on this. So the best way to get when the veins are so engorged is to compress the ultrasound, so that the veins are all compressed. So you can definitely see where the needle is going. So if you don't compress your ultrasound for the veins, you will definitely get into one of the veins, and you will have more resistance.
Just rail the wire.
Yeah.
So key also is to rail the wire when you do this. That
yeah,
should be plenty.
I'm stiffening the wire.
Yep, that should be plenty. As
Oh,
long,
yeah,
as long as
go
actually a
one,
little
go
further,
one.
yeah. I think the key is you want to make sure you're within the vessel, and here you're within the vessel. We try to go up as far up as we can, and sometimes it's a little difficult. There, it's good. That's good. I think you're good.
Yeah.
So right, that's pretty good. You're hanging out about 2/3 out of the thing, and now we're going to give the cocktail. So remember, the key is we're going to attach a syringe to this, and the key is to go ahead and give an ACT. And the ACT is now what? 349. I wouldn't put that in. I would just attach the syringe after giving the cocktail, and then we're going to start to work. I mean, the bottom line is, and also what we do when we give the cocktail is, we're gonna give half of it and flush it, and the other half I just want to leave it in the sheath and in the proximal vessel without flushing it, so it remains as a slow vasodilator of the distal vessel. So what's our cocktail, Dr. Sardar?
Our cocktail is 2.5 verapamil and a total of 200 mics of nitro. And since we are already on angiomax therapy, we will not use the heparin.
So now, right now, Vishal, why don't you and Atul tell me what your techniques are on a wire escalation from the antigrade? What would you guys do? And when me and Karthik will let you know what we're planning on.
Well, I guess, I mean, like we said, our primary goal is to try to see if we can get an antigrade access, especially in the distal popliteal. So I usually like to start first with a hydrophilic wire with a support catheter in 014. I'm not that aggressive to directly go to an 035 because if you find a micro channel, then it's better to connect those intraluminal dots. So start with any of the hydrophilics you might have. If you like Fielder, you like Command, you like any of those hydrophilics. And if that doesn't cross through, then and if it's a real CTO, then we escalate to a stiffer wire like a Confianza or an Ostado, or then we can go up to an 018 segments of wire. What about you, Atul?
I usually, anything pop or below, I usually start with the Fielder XC.
Of getting into the
I think the 0.09 tip is really gets you in where you want to go. I agree, 035 is too aggressive down below here. You also don't have clear channels. You don't have a clear straight path.
Right.
So you need a little guidance. So hydrophilic, I absolutely agree with. You're trying to find some channel.
Correct. Yeah, so that's our goal, is to start with hydrophilic and then escalate up to the heavy body wires.
Give me a woolly wire, guys. So you can see Dr. Guja just left a syringe on this. And what we're going to do is we're just going to go ahead and go down with a woolly wire and get to the level of the popliteal. And then we're going to start working from there. Dr. Kukar, can you tell them what happened with her pacemaker? It was very interesting. One of the things that you experienced with her. No, that was no. Does she have a pacemaker, guys?
No, that was a very interesting case. That was our last patient who decided to go severely bradycardic with 6-second pauses while we were doing a peripheral
While we were
intervention.
doing the iliac, right?
Yeah.
Yeah, I remember that case. All right, so what I'm doing now is just getting this all the way distal, and now I'm going to ask for a fielder wire and try to find a channel. So as we know, so Dr. Guja rightfully is saying that we have both the perineal and the AT to get through. So right now we have AT access distal, and if I get through the perineal from above, likely we'll cross the AT from below, or vice versa. So I think the whole idea would be to establish straight line flow into this ulcer, and see what we get.
PK,
So
do you think taking a picture through the microcatheter now would be good? A little
we
vasodilator
could.
through
Let's
it.
do that. Makes sense. Give me a little
better
dye,
define
guys.
the anatomy, I think.
Makes sense.
Take a hand syringe,
But remember, the anatomy was very bad. So what we're going to do is we're going to take a picture from above.
No, not that. Don't take this one. No, get a small syringe.
Oh,
Don't take a
DSA,
big
Karthik?
syringe. No, you're saying from here?
No, from above. DSA? Not from below. From here, yep.
You want to take from below or
No,
above?
above.
No, just see where we are here.
Just to better visualize. Yeah.
Yeah.
See, that's what we
So
want
now
to
you can really have a good idea.
See, you can see the AT's coming back right there. And the perineal's
perineal
right there.
is right there, right.
See, so let's see where we go. That's one of the reasons, everybody wants to get pedal access and cross from below. Our idea here is to get pedal access for sure to protect our outflow vessel. But the point here is just put a dilator in or leave a wire in. And the reason why we're not leaving a wire in, leaving a wire here is that she's going to bleed around the sheath. So what we did was we just put a dilator, gave some vasodilators, and now we're going to go from above to try to shoot into the into our AT as we talked about here.
Plane.
Oh, that's not it. Give me a bring it a little closer, please, the monitor.
Do a roadmap.
You can take the ultrasound off.
Oh, no, that's not it. That's the collateral.
Yeah.
Give me the monitor. Yeah, thank you. So this is where the steerable catheter will definitely help you. There it goes. It's going there. See, a lot of iliac tortuosity. Thank you. Shut her in a little bit closer, please. There you go. Got a little steerable catheter in. Okay. Let me give me a little dive from above. Ready? Sitting, inject. So I think I'm heading right for the perineal, and I'm going to take it. And I'm going to come from below. Oh, it's not DSA, guys?
Which is the highest likelihood chance is getting into the peroneal, right? Because
Yeah.
peroneal goes straight down.
It's a straight inline.
So there's a good chance that inline flow, there's a good chance you get into the
Well,
peroneal
the point
first.
is, since we have from above, we might as well try to get into the perineal
There
from
it
below.
is.
There's the perineal.
Beautiful.
Right? Now give me another wire. Let's try to get in from the AT from above.
You want to balloon this track so that you
feel
can
the-
get the flow into the AT? If you balloon this, the
command.
popliteal
We can
might
balloon
open
it, but what I'm saying is it went so easy. I
You
think
wanna
I
take
think we
your-
should try with a.
You want
with
to take a
a,
3 balloon and just give it a track so that
Yeah.
you might fill the AT. I'm saying.
I know we can always come from below anyway.
Yeah, you
Guys,
might fill the AT.
Give me a 3.0 balloon here.
3
Yeah,
or 4,
I
3 or
think
60.
that's a great idea, Karthik. Usually, like we were discussing last week of one of the cases we did together, it's like ballooning one of these vessels actually sometimes opens up or changes the anatomy of the concurrent vessel on the side.
Yeah.
And that might give you a better
I
visualization.
mean, it might
on
be
the
a
AT.
hibernating popliteal.
Right.
It definitely is a hibernating
yeah,
popliteal.
so-
But the point is not about the balloon. The ballooning. The thing you have to watch out for when you balloon these, if you don't have access from below, is that if you shut down the ostium, you're never going to get back in. Yeah, 60 is fine. So that's why having the access from below is good, because now we have access from below, access from above, and now what we're going to do is we're going to balloon the perineal, and then if we close the AT ostium for whatever reason, we can always come from below. So I think it's very
a good idea.
reasonable
Yeah.
to have, because I've gotten burnt once in this kind of procedure when you have multiple collaterals, and it was once you get burnt like the way I got burnt, you never want to go back again. And we had to do a cut down on the table. We couldn't get ultrasound access. We tried with ultrasound. We tried. The vascular surgeons tried. Everybody tried. And no matter what, we could not get ultrasound access. So we actually
strange. I'm not
physically cut
getting
down on the
resistance.
dorsalis pedis. Turned out to be an aberrant dorsalis pedis. And then we were able to get access, cross from below, and then took care of it. So we're going to now go ahead, like Guja and Dr. Guja and Dr. Kapoor suggested, balloon this. Watch out, that wire is moving too much
Yeah,
because you're in a collateral distal. We're going to go ahead and just balloon this segment. Let's start here. Actually, maybe a little bit lower. Let's start right there. So we're going to just go slightly here. Small balloon. We've got a laser catheter available and an IVUS available, just in case. Just a slow balloon.
And that's where your AT takes off, is that lesion.
We hope.
Yeah.
There you go. Okay, leave it up a little bit. That's good. I'm going to come back from above.
Pull back.
Yeah. Let's go up
A
here.
little bit more.
It's okay. Let's go up.
The wire PK. What's the wire tip?
Came all the way back, huh? That's good,
You
though.
want to wire it now?
It's good. I like to have the wire really close to me. It's like my good friend. So we're going to balloon this. Good. Karthik always makes fun of me. So he's always pulling the wire out, but he blames me. Go up here. I want the audience to know that I'm the most abused physician in the world.
Most.
Audience is crying already.
Down. All right, so.
The audience is quiet.
Yeah.
Sorry. You have
All
no
right,
support.
DSA. So Atul, I want you to see the, sorry.
Yeah.
I want you to see the abuse I'm taking, Atul. All right, so here we go. Hopefully we have a good flow now. There we go. That's nice. So we got some flow down. And there you can see the ostium of the AT.
Ostium of the
See
Yeah.
that?
You see that
So
competitive
now
flow right
now
there.
we're gonna go. We're gonna pull this. We're gonna leave the wire there. I'm gonna walk the balloon out, and I'm gonna go. Actually, we're gonna go from below. Karthik, why don't you go from below? Because actually it might be
Feel the
occluded
wire.
from
Feel
below.
the-
Let's take a better picture.
Coming.
I think there is a proximal occlusion from below, but still
Well,
below
let's
might
see.
be a better option rather than taking that acute turn takeoff of the AT. But
Well, I think we'll get in, Vishal. I really do, because you see it's occluded here.
yeah, that's what I said.
So
It's
the point is,
proximal.
we come from below, it might be fine. But what we'll do is we'll have Karthik wire from below. Actually, before you do that, Karthik, let me walk this out. Give me my vert tip catheter, guys, so we can steer it into the vert tip. 1 second, I walk this out.
Yeah.
So what we're going to do is, in preparation of this,
What
we're going
about
to take the
the
vert tip catheter down.
This wire.
Yeah, wire's down below. Yep. Let's walk it out. And so we're going to leave the vert tip at the level of the pop. And then let Karthik wire into the vert tip.
So I guess the question I have is, since you already have
Yeah.
into the perineal, if you have to try from the top, you have to pull your perineal wire out, which you don't want to. So
No,
you
but-
essentially are restricted from
Double
going from
wire.
the bottom.
Actually, that's not true, Vishal. We could actually double wire it. So what we could do is I put an 035 catheter down, right?
So next to it, not on
Next
it.
to
though.
it. And then right through that 035 wire, go with another hydrophilic or go with a 014 or 018 stiff wire. So
Yeah, I
right
think-
now, if Guja gives me a good rail, which is tough, we're going to go down. And then once we get close, I'm having a little bit of resistance up top. Show me
Probably
a
on
little
the
bit. Yeah.
right where you're.
We got a lot of stents and all that, so we got to be careful. And I think the key here is to really watch everything as it goes down. Yep. let me just switch here. Well, you don't want to lose the wire position. There you go.
One second.
So you know what Dr. Guja and I did was we both torqued because we're on an 014 wire. He torqued and I torqued, and we were, see, now I'm going to leave that there as a target for him, and he's going to come from below. So remember, the key here is below is you don't want to go ahead and get, you're going to have to kick the floor to yourself.
Yeah.
You don't want to go ahead and get into a dissection plane.
Yeah,
So-
just regular flow.
So-
Okay, how about, I mean, I know we could probably try this, but how about using an 018 catheter next to it, keeping this wire down and then trying to do it? Because here now the torquing of the word tip will be restricted by the primary wire going out to the perineal.
Yeah, I totally agree, Vishal. I think that, see down below, I think we're going to have to work from above and below possibly.
Okay.
So what Karthik is going to do is try to get this down. He's going to need a support catheter. So we could use a fine cross for
Fine
him
cross.
and then go up. See, it's already going up. It's a hibernating vessel, which that's a good sign because you know that means you're intraluminal. And see, right now he's just going to keep wiggling it up and it's just going to go right up. I think we'll be fine. Show me above now. All this kind of stuff it's an occluded vessel, so it's a little bit of distal, what is it called, dissections.
Right here,
So-
calcification.
So right there, you can see all this is a hydrophilic wire. So he needs a little support here. So why don't we get him a fine cross, or what are we getting? Six side?
See it.
You can get a balloon actually.
Well, let's go. Why go from balloon from the foot? So another thing I try not to do is balloon from the foot. There's no reason, especially in this situation. You
yeah,
know you're going to cross. You already have convinced yourself you're going to
fine
cross.
is fine.
So what we're going to do now is we're going to change out, walk out the dilator, and we're going to put a fine cross in and let Dr. Guja work. Because see when that wire starts to do that hula hoop, see that hula hoop? Can you just twirl it a little bit, Karthik?
Yeah.
You see that hula hoop where you start seeing that little hula hoop like Elizabeth used to do when she was a little girl? That is exactly
There's our occlusionist.
the point which tells you that you need to have a support
Yeah, take this.
catheter. So don't push at that stage. When you push at that stage, what you're going to do is you're going to end up dissecting the vessel and/or creating a fracture of the wire, which Vishal is very famous for. So it's very important that you don't do that. Atul, what's your wire of choice from below?
I literally live with my Fielder XT down there.
Okay.
I think that's the wire, and I 100% agree with support catheter. I like the style of trying it without the support catheter first to see where you're getting stuck,
Right.
or where you're hitting resistance, so you know at what point you may have to put especially if you're higher up in the leg, a stent. Where you've gone intimal, subintimal, and back in.
Right.
So I think that's a good strategy. But I agree. Once you start seeing it buckle, or what you call
Keep the
hula
wire.
hoop, then I agree. Take an 014 and give yourself a little support.
So Vishal, I mean, your wire, brother, from below?
No, it's the same thing. We try to use a hydrophilic wire. You can go Fielder, which is a
Okay, now
great
you got it
wire.
right.
You can do Command, which also
just
works
hold it here. If you
good.
tell me when
So
you want me to
a
advance.
hydrophilic wire, finding that hibernating microchannel
Yep.
Yeah.
Well,
is the
advance
best
a
way to
little
go.
Yeah. I got it.
bit. Okay.
You have to use a stiffer wire here.
What's your feeling about using a whisper down here?
Yeah, actually, Karthik is saying he wants a stiffer wire, which I agree with him.
Yeah.
You see the calcium that Karthik is
It's not
having
gonna
trouble
tear it.
with?
It's not gonna tear
I
it,
think it's
but
not going to
gonna
go. So
dissect
we
it.
need a stiffer 014 wire. Give us a Win or a Confianza, guys. I think we'll go with the
Confianza is
Confianza.
good. Yeah.
We'll go with the Confianza.
Yeah.
So the one person we're missing today is Sandeep. Dr. Singla is basically outside coaching us, and he's a big fan of the Confianza. So we're going to the Confianza in his honor here. So once we cross Karthik, the question becomes is, what's going to be a modality of treatment?
I would treat from above.
Yeah, of course,
mhm.
100% from
I
above.
I would do laser here.
I think I've decided I agree with you. But the question here is, what I want you guys to understand is since we have access from above, if Karthik has a little bit of trouble from here, we'll stop. We'll come from above and below
Yeah,
and
and
try to
touch
meet
the
and try to meet the wires and maybe do a cart or a reverse cart. So he's got the fluoro, and what we're going to do is we're just going to be very gentle here. We don't need puffs. We've got targets. You can see the calcium very, very clearly. Use the angiographic access that you have to tell you.
Sorry.
And look how nicely he's going to move it. It just looks like a little lateral there, but let's see. Let's see how it moves. Let's see how it moves. You never know. You're going to get subintimal, back intimal, and that's how it's going to work. So, he's just going to, there he goes. Looks pretty good to me here. They're moving very, very freely. The only point is at some stage, sometimes here you can get into veins, and I'm going to just advance this a little bit. What do you think, Karthik? Yeah?
No.
No, not yet?
Not
Okay.
right now.
We'll create a track there.
Well, yeah, I know you're a little worried about that bump. I just think you went out and came back in. There you go. You're in the vessel for sure. Hold on a second.
No,
So you
one
can tell
second.
you're in the vessel.
Yeah, I
So
will.
now I'm going to go ahead and push this.
1 second.
Okay. And I'm just being a little aggressive. Like, Usually try not to be. Okay, right there.
That's it, that's it.
Now we're going to go up. And now what we're going to do is now we're going to give a puff from above. Let's do a roadmap, Karthik, so they can see. We're just
you
going
know
to do a
what?
roadmap so
Actually,
they can
I'll
see.
switch it to a hydrophilic wire here.
All right, give us a hydrophilic wire. And let's do a roadmap. Let's do a roadmap before we do
Command,
it.
Dr. Krishna?
Yeah.
Yeah, you can give me a command or a fielder XT. Let's go with Dr.
What's up?
Kukar
Field
with
XT,
the fielder
please.
XT. Let's do a roadmap.
It's roadmap, yeah.
So I know we're using a lot of coronary wires, but I want to point out that that Dr. Sardar said the right thing. You can go with the command. You can go with the WIN. You can go with any one of these wires that you want. So you can see here, there's the ostium, and now he's trying to come back in, and I'm right there with my catheter for him to have a target. So he may or may not have. See, he's making the nice turn, just the way we talked. See, and there we go. It's looking good to me, actually. But I agree with Karthik.
It's
Here
too
it's a
aggressive
good
for-
reason to go with a command wire, which is very torqueable. 014, 018 comes in extra stiff, as well as I think extra stiff, as well as
Extra stiff, yeah.
and just regular stiffness,
Yeah,
right?
extra torqueable.
Extra stiffness and very good torqueable wire with the tip that's not destroyable. So you know it's not like our coronary wires, which get all destroyed so often in the tibial work that we do. So now at this stage, what we're going to do is we're going to have him torque up. And this is a really good case for everybody to watch because you know now we've obtained both perineal and this dorsalis pedis. You can see right there, dorsalis pedis axis, beautiful. Okay, now I'm just gonna. I should track up for you, buddy. There you go. Let me give you a little support because I think that you're gonna dissect if you don't have the support. So I'm just tracking up. This Karthik, so Dr. Guja right now is pulling the wire,
That's
and
good.
I'm pushing the catheter just to give him a little bit of support.
me a
We're almost
torquer.
there. He's just gonna pop right in. If not, we'll go with one of the WIN wires, which has a better tip to get into these type of difficult vessels.
That's a good
Or
sign.
I can come from above, one or the other, you know, and this way we can meet the wires. It's okay. Loop technique is fine with me too.
No, I think
I know,
we'll
I agree with
dissect
you.
it.
I agree with
This
you.
is- you're
We
so
can always
close.
pull the wire. You can try to find another plane too.
Yeah.
Yep, I'm going to pull the catheter back a little bit so Dr. Guja can try to find a better plane to get back in. There it is. That looks much better to me. Oh, okay.
That's actually.
There you go.
That's better.
That's much better. Let's see if it pops up for you. Our young lady is moving a little bit. There you go.
That's okay.
Almost. Now I think you need support, bike. So I'm going to push
Yeah, I
this
need
up
a little bit more
little bit of
heavier
support.
tip. Yeah.
That's good.
Okay,
That's
that's good right there. Sometimes these little cap re-entries are the hardest part. So let's go with give him a WIN wire now. Yeah. And give me my old wire from above. I'm going to come from above and below.
Which one was that?
No, give me. I need a sharp tip wire from above. So give me a WIN from above, or actually give me a Confianza from above. May go down. If it goes down, it's fine.
No, it's a plane.
It's a plane.
Definitely, 100%.
Okay, here's a WIN for you, Karthik, if you need it. Do you need it, or you want to stay with the fielder?
I think fielder is better.
Give me the other one. Yep.
Confianza.
Mm-hmm. So I've got the WIN from below. I mean from above. So
Karthik.
Vishal,
You want to take the loop?
yeah, we can do a loop technique. That's what we talked about, me and Karthik. You could do loop. No te mueva, mamita,
Ah,
por
she's
favor.
moving.
I think that's a big pretty.
Yeah, it's now it's because the
it's a
catheter is
plane,
probably
no?
a bigger plane now. You have to pull back your catheter and probably just.
Yeah.
Okay.
Yeah, there's your
Hey, that's going to be too big.
too
Yeah,
big of
too
a
big.
That's too big. That loop is too big.
Yeah, definitely.
So the other thing we could do is trade up for an 018 wire from below, catheter
good
from
plan.
below, and switch to an 018 Connect 250T, which will also help here. Your wire.
Yeah, no, I got it.
Okay, come off roadmap here, guys, so we can, so Dr. Guja and I both can see what we're doing.
Off Flora.
Off Flora for a second, Guj. Off roadmap.
Yeah, we are.
Yep.
That's a good plane.
Okay, give me a little puff ray.
That's a good plane. I like that plane.
There you go. That looks pretty good for me.
Yep,
There it is.
there it is.
Okay, I'm definitely there.
I'll wait for you.
Well, let's hopefully we'll come in together. The problem with 2 wires here is that I have very little, like Vishal said, ability to move this wire.
We
I
found
am
the
touching your wire.
Nope.
It's a plane.
There it is.
nice.
There it is.
Yep.
Can you move your catheter, Karthik, a little bit? Bring your catheter down. Bring it mag up. Now bring your catheter a little lower.
Yeah, a little
A
bit.
little lower, Karthik, with your catheter. Okay, now, fluoro. Okay, bring your catheter
Your
down.
wire
now.
back,
Catheter
yeah.
down. Keep bringing your catheter down. Give me a torque from above, guys. Let me see whether this thing.
Second talker, please.
No. I'm moving. You can see I'm moving the vessel. Okay, let's come from below now. Let's go to another view. Show them another view from below. Show me another view. I would switch to a wind wire from below.
Yeah.
Go contralateral, Ray. Flora. Okay. I'm just going to bring my catheter down now, up top. There I am. There you go, Karthik, right there for you.
This is on your speaker.
Mm-hmm. So we're going to go a win from below, win from above, and somehow we're going to win.
Oh, all right.
There
I
you
don't know. I don't like that from below, above. You see that? We're off. I think he's going to cross from below. Hey, pull back and let's try again from below with a not a non-hydrophilic wire here. So the other option is an 018 system. You know what, Ray? Give me a hydrophilic wire from above. Flora?
Command.
If you can create a plane, touch 2 planes.
Yep, and then we just balloon it.
PK, you want to throw a micro
Oh,
catheter
yeah.
over your wire? It looks like that osteal anterior tibial you got in nicely. Maybe I want to lose that by coming out and turning a different wire.
I just feel like this is moving too freely, Art. You see, I got a lot of
It's a
grittiness
big plane.
Yeah, it's
Dr.
probably.
Cooper.
I mean, see, it's going in the right direction. See,
here. Yeah,
There. What
it
I-
is, but it's not.
what you could do is probably keep the wire there, take your 035 catheter out, put that.
See, if you
01
go in the other direction, you'll see how far you are from
I'm
the vessel.
sure. I mean,
Yeah.
well, you don't know, but that's what I'm saying. Even distally, you might be a little bit off
Keep
plane.
pulling
So
back,
this
yeah.
might work a little bit better. You can connect the dots this way. Yeah.
Let's
See,
see.
now it's trying to get into that plane where our catheter is.
Yeah.
This is the whole idea of above and below here.
The only.
You know, remember, I mean, you're constantly making planes, right? So the idea would be, there you
You're
go.
in the same plane.
Now move out.
You're
Move your
definitely in
catheter.
the same plane.
Move your wire, I mean.
Yeah, wire back. If
Move your
Karthik
wire
can
back
move
a
your
little
wire
bit.
back.
Your wire back. Your wire's back.
Yeah, it
You're-
looks.
You're definitely in the vessel.
Yeah?
You're in the
think?
vessel.
You
You're
think?
definitely in. Yeah.
Let's see.
Yeah.
All right,
It's
let's-
definitely going in the same direction as the catheter, so. Probably a different
Yeah,
plane, but at
really?
least in the same line.
Keep coming down.
I think we're going to have to balloon this personally.
Yeah.
Nope. See, it's doing that Vishal twist.
We shall do.
There you go. Which wire is it? The wind?
Dark. Yeah.
Yep. There
Give
it
me
is.
a torque.
That looks better. That looks much better. There you go. Right there. Now bring your catheter up. Bring your catheter.
we're
Push your
definitely in
catheter
the
up.
same-
Yeah, we're in the
same
same plane now. Now pull your wire back. Let's see whether we can squeeze.
Push it. Push it.
I'm going to push the catheter as we. There you go. Beautiful. Nope. We missed. Let's see
You're
where it
right
goes.
next
Go
to
up,
it.
Give me a darker.
go up. Okay. Let's see, Karthik. See where that goes. So the beauty is we've created a plane from above and below.
Yeah, we might have to balloon from above, PK.
Yeah. Looks like it, huh?
We might have to balloon from above to get a.
No.
Yeah,
Nope.
that's the plane Karthik was in, the big one. But I think I like the plane from below. I mean, from above.
Okay, we'll leave the catheter here. Let's do it from below here. Pull your wire back, Karthik, a little. So I'm going to try from above here to try
Yeah.
to get into this plane.
BK, can you advance your wire?
I'm just trying to pull the wire back and try to get into the Karthik's catheter.
So why don't we pull Karthik's catheter back?
No,
a little
actually, I
bit
like
and
it where it
advance?
is right there. See, right there, I'm below it. One second, Karthik. Yep.
I'm just giving you.
I know you're trying to get a better plane. There it is. That's there. Ah. All right. Well, we're definitely in something here.
You want to get another orthogonal view? So that would
There it
there
is.
it is. There it is.
Yep. I think I'm in. Go to another view, Karthik, bye.
Yeah, watch your legs. BK.
Mm-hmm.
Yeah,
Yep, we're
you're
in.
Yeah, you're in.
That's it.
Definitely.
So now we just need to push this forward. Let me just say, Karthik will just pull the wire back and push the catheter. No, we're not in.
We are not in.
See? We're not in.
We're right behind it.
You think we should balloon from below?
We
Or-
can. Balloon from below, above and below. Why don't we balloon from above here? Give you a little cart. Show me below, Karthik,
One
bye.
second, BK. I
That
think
looks better. That looks a lot better. Nope.
the
like
same
I'm in
thing.
Your plane.
Why don't we take a picture from above? Ready? Ready, guys, DSA? 1 second,
Off
Karthik.
Flora?
No, I'm in your plane. I can feel
Yep,
it.
I can
Flora?
feel
I
it too,
can
but let's
feel
just take
both
a,
wires
she's
together
moving a lot.
actually.
Let's just take a picture. Mama, no mueva. Cindy?
DSA? or-
DSA? Okay, nothing bad is happening. We look to be in a good spot, both of us. All right, let me see below. You know what? Let me have a, I can't put a Trailblazer, I'm not a Trailblazer, 014 wire here, right? We can pull your wire back. Let's see. Where's the catheter?
Well, I'll advance the wire from the top and see how far it goes
I
down.
just want to see what, the catheter is way below now. Wow. Advance the catheter up. Hold it right there.
I think if you balloon,
Nope.
went into a totally different plane.
Nope, I'm in a different plane from above. I'm probably in the vein, who knows. That looks a little better. Oh, nope.
You might be in a vein, BK.
I might be in a vein, I agree. Oh, they see we're moving one another, Karthik, see?
Well,
Advance
so
it,
very
let me get
next to
the
each
vein
other.
catheter
also.
from below.
Both of them are snuggled together.
I like
Alright.
this better than that, BK.
I like your plane better too.
Yeah.
All right, let me try from,
Yeah. Go
give
ahead.
me, let me give a shot here.
Yeah.
We both will try. Give me a hydrophilic wire.
The Flora is
Linda?
with you.
All
This
right.
this is a new plane, so try this and see.
This looks actually better than my plane. Oops. Nope. That's the same plane as before.
I think if for somehow if you can get a loop down there, that'll be a.
I agree with you, Vishal. Bye.
I know it's tough, but yep.
Okay, give me a hydrophilic wire for sure.
Feel that?
Yeah. Ah, that's better.
I don't know.
That looks good, but right there, stay there, stay there. No, we're definitely touching. Stay there, stay there. I'm coming to you.
It looks like you are, but I don't think we are.
Definitely close enough to do a cart. Okay, ready? Okay, go. Pull back.
No, right behind it.
No, the other way. I think a hydrophilic from above would be good. Nope. There it is. Nope.
No, they're just like next to each other.
Okay, yeah, you're not in the right plane. Leave it there though. Let's see. Pull your wire back a little, Karthik, now. Let's keep pulling your wire back. That's better. Nope, that's the vein.
Yeah, that looks better.
Hold on, let's see in different views here.
It looks promising.
Everything looks promising, but let's take this up. Hold on, you stay there. I'm just taking this up. Okay, now try. Nope, just missing. I think time for a cart.
Yeah, agreed. Balloon from above, balloon from below.
Give me a hydrophilic from below. Hold on, right there. I even like that even better. Actually, ooh,
It's the same.
give me a hydrophilic wire.
Okay. It's ready.
1 second, guys. When you wake up, it's a new morning. Liz, can you sing? Vishal?
No.
This is the part that Artie always says, it's like watching paint dry. I need some help from the two of you guys up there.
What do you think about putting an ultrasound probe down?
It's a good idea. Karthik, you want to try with the ultrasound probe? We've done that before.
Not here.
gonna work in
No,
this.
it's very-
I don't think it's going to work
Yeah.
here,
Okay.
Atto. Because we have created so much
many
planes.
planes. Yeah.
It's going to be very difficult for us to
We
get
need to
into
pull
the
back
right
from
lane.
up
Looks
top.
like a vein. PK.
I think it's
Yeah,
one of
that's-
you
that's
are in
good,
the
that's
vein.
good, that's
It's either him or her.
Just stay there.
I
I'm
mean,
gonna go.
Him or her?
Karthik or PK.
That's good. I like that, PK.
Okay. Now pull the catheter back a little on your end. Okay, let's see. Vein.
Yeah, the way it prolapses.
I'm in the vein. PK is in the vein. Oh, it's a calcium though. Give me a sharp wire here now.
Yeah,
That's calcium.
That's calcium.
That's
good.
calcium. Give me a sharp wire here now.
Confianza?
Oh, any sharp wire. Here, let's leave
Yeah.
it right there.
Try this. You
Think
want to
so.
poke it and see?
No, not without a wire yet.
No, I'm saying.
Not yet.
It's,
I don't have a
not
really
Confianza. Give me a
dense.
Confianza 12, please.
Connect
Connect
250T?
250.
Yeah, give me the connect.
Yeah, it's.
Did you make a curve on this?
Breaking that calcium cap that's what the issue is right now. So
Yeah, hydrophilic wire. Command or something. Command. Take a command.
Feel that?
The other thing also we can do is do a, you want to do a facilitated reentry?
I was going to ask you, what do you? Yeah, I mean, we just have to take our wires way down from the top to get a re-entry next to it. But then again, we're not sure we're in the vein or not. So that's where it becomes technically challenging.
All right, Tarker, buddy.
I don't think facilitated reentry will work here, Vishal, no?
Well, I mean, unless you're way in the mid portion where our dissection plane was not as big as the proximal segment. But again, from
But
top,
Karthik,
like
wouldn't
PK
an
said,
ultrasound help here or no?
No.
no, because there's
Because
a lot
of
of
the
vein-
dissection planes we created,
Yeah,
it will be hard to know where we are.
it'll be really hard to define the anatomy to see where we are actually with the ultrasounds. It might be very technically challenging.
Because wherever we are, our flow will be better in the dissection planes.
See, I think here what it does is just spiraling around. I mean, we're in the artery, it's just like a.
Give me a Fielder XT now.
See, it's just.
Not working. All right, let's go with an 018 wire now. Yeah, give me the M, but I'm going to go from above with the M.
Karthik, you want to try? Yeah, I was going to say, you want to try with another wire from the top and see if you can
I am using a command wire.
Yeah, leave
get
it-
down. Yeah, I think command is a good
that looks
option.
good
Get
right
down
there.
and then
Leave it
try
right
to
there,
do a
leave it right there
card.
for me as a target.
Yeah, that's your spot right there.
Shaper?
Shaper is.
Shaper, guys?
Here's
Give me another
yeah.
shaper.
Okay.
Sada, can you put
Yeah.
torquer on this one?
What you could do, Karthik, is probably exchange the top catheter to an angled Trailblazer.
Yeah, but the
018.
problem is you're going to lose the perineal then.
No. So you take the 035 catheter out, you put an 018 Trailblazer next to it
Right.
with an angled, and then you can have your independent approach to the AT, keeping the wire in the perineal.
Here is the Karthik.
Puff a little bit, Sardar.
Hmm?
Just puff a little bit.
I think that loop is good.
Yeah, I'm just going to
It's
try
just
to
the dissection
wide.
plane. Yeah, it's too big. The problem is the entry. There.
Question is,
Yeah, too many. Oh, that looks like
I don't know
it's
if
probably
it's
just spiral
artery,
all
PK.
the way around.
I agree. It's not the artery. Ah, that may be the artery.
Uh,
DSA? Let's see.
Oh wow.
Yes.
so You think you're probably in a collateral? I don't know. Maybe nothing.
Oh, that's
No. We're
in the
out.
vessel.
It's definitely in the vessel.
That looks like it's in one of the branches.
Yeah, let me try another view. Karthik, watch your knees.
Yeah, it's definitely in one of the vessels.
See, it's in the branch.
It's in the branch.
See that?
There's no doubt about it. 100%.
See how it's in the branch there?
100%.
See that, Vishal?
Yeah, I think you're right. We're in a
So
branch.
maybe maybe what I should do is move this forward and then take a picture. Okay, give me a little syringe, guys. Wishful thinking, huh? No,
Yeah,
looks
blood
like
flow.
we're okay.
Yeah, blood flow, you're okay.
Well, let's see. Not really.
I mean, even if you don't get a lot of blood, I think this is a good technique because it will decrease the hematoma in the dissection plane and probably give you a little bit more option rather than just looping in those big dissection planes. So just a negative 3 cc syringe will decompress, so-called, the stuff. So it might give you more option.
I'm definitely in a vessel. Yep.
Fluoro, Sardar?
He has it.
Yep, I'm in a vessel. Give me a little die. Give me a little roadmap. Hold on a second, Karthik. Give you a little die here. Roadmap.
Roadmap.
Mhm.
Just give a little bit.
Of course, yeah. I don't want to hydrodissect it
Yeah.
here.
Oh, so you're filling the peroneal.
I'm filling the perineal.
And that's like,
So the question is
Through a branch.
it through a branch or is it through the DP?
To the branch.
Yeah?
Yeah.
to the branch.
Definitely
to
through
pull
the
back?
branch. See, that branch is connecting both the peroneal and this.
Yeah.
That's what it is.
Save that if Flora saves so far, Farhan.
You can balloon from below. Okay.
Okay. Let me give me a Confianza now.
Confianza.
Let me go to another view here. Let me just get a better view. Let's go to lateral view.
No,
Let's see where we are. Hold on.
It is confianza.
To dissection.
So there's a dissection.
All right, I'm going to pull back. Confianza. All right, any thoughts, guys? Should we just bail out, take the perineal, leave it, or are you going to keep trying?
I mean, I guess the only thing if you want to be a little bit more aggressive is
Balloon
upgrade your
dilatation?
lower branch to an O1-8. Like last resort, what I would do is probably do a
There you go.
V18
That
from
looks a
below,
little
loop it, and see if you can connect it. But otherwise, we just establish perineal flow, bring her back, let it heal,
There you
and
go.
bring it back.
Oh, I like this. I'm going to pull this back. Hold on. I'm just going to keep pulling this back. Keep coming.
Yeah, so I think somewhere in the mid shin you went
Yeah.
subintimal.
Right there.
And I think that's where the
when
wire.
Karthik kind of went outward. I think that might have been the reason.
Right, that's what I'm saying. We probably have to pull back to the mid segment and try to see if we can.
I like this better.
I like this better too. I think you are. Why don't you put an 018 catheter through that?
The question is, we have a.
I think, what if you just loop it?
Try to loop it. That's what I would do too here.
I mean,
Well, it's not going to loop up there. You got to loop down below.
well,
See, it went outward.
yeah.
Karthik, what wire you have?
This is a command.
Command.
Command is good to loop, right, Karthik? Yeah.
Command
The
looks
problem
good.
is you don't have much support from the top.
That's the problem. I think you got to give up the perineal access.
Go. Push.
Ah,
It's too big, man.
too
No,
big.
we need that support catheter for the good loop to work. So, now see, now it's all in that.
Vein.
Yeah, there's no doubt about it.
I think we're in and out. So,
So PK, I like the
I
trial of starting from the DP again with an
That
018.
looks better.
You have a good track down there. Try to come up with the
Yeah, it's the
018,
same plane
give it a
you were
fair
taking.
shot, and if not, get the perineal open.
There you
get,
go.
Get some flow
You're
down.
in. There you go. Perfect. See that? Marked beautifully.
I don't know if
You
I
are.
can-
You're in. Push. You're in. Hold on, watch, stay there. I'll show you my wire. Where's my wire? Show my wire. Where's my wire?
That's your wire.
No, that's Karthik's wire.
My wire. What happened to your wire?
No, my wire is all the way out. Hold on, let me find my wire first. Hold on, Karthik.
That's your wire.
Catheter's right there.
Can you just mag out, Karthik? Yeah,
Hold
wait.
on.
In two up. What?
Where is your wire?
Mag out, Karthik.
Yeah, it was all the way out. Hold on 1 second, guys. I think we're through. I'm just going to introduce my wire. I want to touch Karthik's wire here. See, this is what happens. Yeah, you're definitely in. Hold on, let's show them.
I can feel it. No,
Yeah, you're in the vessel. Look at this, Flora. Give me off corner. So I think multiple dissection planes, and then you find it. That's all. See? So here comes my wire from below. In 1 second, and we're gonna. I love give Karthik a good morning kiss. Oh, look at that. Hey, how are you? Good morning.
Good morning, BK.
Flora safe. Okay, Flora safe. Okay, go ahead. Now just push it down. Push it down. So what we're going to do is externalize the wire, and then we're going to work from above. That's all. Oops. That's it. Wire is externalized. Push it out. More. Okay, good. Good. That's out the catheter. Flora save this. Ready?
So what I would do is I would
Now I'm just
cut
going to pull this
BK.
out. No, just pull it out.
No, catheter is,
second,
yeah.
One second.
Flora safe.
No, one
Off
second.
Flora?
One second.
Mm-hmm.
Quick. Just a moment.
Mm-hmm.
Okay.
Okay.
Show me.
No, just we're going to pull this
no,
out.
No, wait.
You're in the catheter, no?
Wait.
I would push the wire down a bit more, yes.
Yeah,
Okay.
Wait, don't pull it out.
Flora safe again.
Just a moment.
Okay. All right, we're out. Ready? That's it, we're out.
I got it.
All right, so now we're gonna work, guys. So let's walk the Trailblazer. Let's walk the, now give me two. Now we have a 6 French system, so we're gonna have to individually balloon this. So let's give me another 3.0. Give me a 3.0 long balloon. Walk this out, Karthik, for me now.
1 second. I just want to clip this so that we don't lose. Give me a clip.
Take a torque.
No, not. Oh, actually,
Yeah,
that's
put a
not
torque
bad
in the
idea.
back of it, yeah.
That's not a bad idea.
So one of the techniques that Dr. Sardar is saying, he's just going to put a torquer in the back of that so we don't lose this. So the torquer is going to be locked on the back of this wire. Can you show the camera, please? Can you get us off the small screen to make it a big screen, please? Thank you. Yep, you can see the torquer that he's putting on.
If I can put
And
the
you can see the
in.
torquer is going to be at the edge of the wire to prevent the wire from moving while I'm working from above.
I can't put the torque.
Okay.
Go ahead.
Throw a clamp on it also if you have
You
one
can put a
available.
clamp on it. You know, that's also a nice thing you can do. Generally speaking, this is another nice technique also where we can do it. So now we're going to go ahead and balloon.
Good.
Yep.
Nice.
No, it's not going.
No, it's not going.
If not, just do a clamp. Yep.
Yeah.
We'll just do a clamp. We're trying to
Cool.
get too cute here, guys. So the command
got it.
saved the day. Okay, Flora, let me walk this out now. Low mag, please. Low mag. Okay, so now I'm just walking this out together. Since I have the other one down, I'm not have to worry about anything. You can let go. There you go. Thank you. Go ahead.
I'll walk it.
Karthik is walking it out. So the nice thing is we have 2 different wires. One is a fielder, one is a command. Fielder in the perineal, command in the anterior tibial. Now we're going to balloon the anterior tibial. It's out, Karthik. We're going to balloon the anterior tibial.
Watch out, Flora.
Yep, you got Flora. I don't. It's with you.
The question is.
I got
don't
both.
know if the wire came
Yeah, I
out.
got both wires.
Yeah.
All right, put the 3.0 balloon. We're going to put a 3.0 Armada into this. Can we work a little faster, guys?
Yeah.
3.0 Armada.
Taking a 200 millimeter.
We're taking a 200 millimeter Armada, Art, and we're going to balloon this. And then once we balloon it, we're gonna see how it looks. And then we'll take it from there. So obviously we have 2 different wires, 2 different colors. So now when Karthik pulls it to me, we're going to go all the way down. No wire yet?
No idea.
Okay, which is fine. We can just.
I'll hold one wire. You can
Yep,
keep.
you just- yep.
Yeah, I have a wire.
You got it now? Okay, good. Flora? So we're going to take it straight down, which is fine. I'm happy that the fielder is back a little. It's not causing any perforations
Hold
or
this-
any issues.
Hold this one.
So I'm just going to take this. There's my armada going down. Now I have through and through rails, so this baby will go. Hopefully.
Watch your wire.
Yeah, I am. All right, let's just balloon here for now. Let's clear the track here. I'm surprised the armada's not going because I think it's one of the best balloons in the market. So we're going to balloon this. And when you balloon this, what you do is you get rid of a lot of the resistance that you have. Now, Armada, is this 6 French or a 5 French sheath compatible?
5 French feet.
5 French, okay. So you can see here the ballooning is occurring. That's the air, that's the cap, okay, down.
One sec.
Okay. Okay, so hopefully, so what I'm going to is pull back and go forward. Try to break through this area. Right, so there I'm pulling back, very tight, and then try to go forward, and it went forward.
watch your wire,
I'm
watch your
okay.
wire.
Perineal.
Go
What's
up
the other
again
wire?
here.
What's the other wire?
Yep.
Yeah, I think that's where you're.
So a little bit of pain.
She has pain.
That's okay. So, so this is sort of our way of ballooning the track. The question is, as far as laser and then followed by definitive therapy, would anybody do a coronary DS here?
I guess it depends how it looks. I mean, I don't know about the atherectomy. We created so
Yeah,
much
that's good, that's good,
subintimal plane.
Let's balloon it again.
I'm not sure how much that's going to help us in this proximal segment. So I guess we just balloon, see how it looks, and then we can define how much residual lesion.
Maybe we should go with a coronary
stuff you
balloon
have
here,
and then
huh?
make a
No, I
decision.
think.
What do you
we
say?
are
It's not
okay.
going.
I think if you get the,
Keep going, keep
I think
going.
I'd
I
like
think
to
we
see the
got the
perineal.
district
The perineal is nice and open. I would be a little less likely to stent the AT. I think the idea is we would just want to heal that ulcer. I think we give her 3 months, get the
Go ahead,
perineal
now,
open,
no,
and may
go
get
ahead.
some more collaterals to come in later.
It's not
So
going.
I'm with the more of a
Okay.
balloon and avoid the
Should
atherectomy
go
for now.
You
I agree.
through the district cap.
But it's not going. See?
You might try
bending,
want to
it's
use a
bending.
shorter
One second,
segment
one
balloon.
Yeah, we're gonna get a
Yeah,
coronary
we're going to
balloon.
get a coronary balloon.
And let's take a picture before
Yep.
we do the coronary balloon down there so we can see what we
Okay, down.
opened up.
It's moving.
Can you walk this out quickly? Get us a coronary 3.0 balloon, please. So Dr. Guja is going to walk this out.
Yeah, I think your strategy to the AT changes because you got the perineal. And I think that's probably the key to the foot.
I think you're right. Yeah.
Okay. That's yep. There you go. So for me, as far as I'm concerned, I'm going to put a drug-eluting stent, Art, if it's all right with you, because I think that we've dissected that ostium so badly that I think that we're not going to get away without a drug-eluting stent here. Whether we do laser or no laser, it's not going to matter. I think in this situation, we have to put a drug-eluting stent in order to help this young woman heal her wound.
What do you think, Vishal?
No, I mean, like I said, we'll just get a picture initially, but probably the feeling I have is probably we might need a stent in the proximal segment, especially when we know that the data clearly suggests
Actually,
that.
I agree with PK too. On this.
This is so shocking to me. The two of you agree with me?
Hold on.
Okay, go down. Go.
There
down.
you go.
Go down. Okay, let's start ballooning from here. No, right here. Start ballooning from here.
Because
So
I
we-
think even for the outflow for that stent, Atto, I think you need to have a good vessel. I think that
Mhm, come
perineal
forward.
is not enough
Negative.
because it doesn't go down to the level of the foot. But
Down.
your AT forms your plantar arch, so that's your major vessel.
Right.
Flora.
So even if you lose the perineal, you should be okay with it as long as you can secure your AT.
Go up here.
I mean, and also the data on below the knee stenting is actually very good. I
Down.
mean, good patency rate. So especially in this patient who definitely has an ulcer,
Flora,
I
please.
think stenting is not a bad option.
Go up here.
Yeah, if you stay at the ostium of the AT and stay in the proximal third,
Yeah.
or even the proximal 25% of the AT, I think
We
that's
should be good.
reasonable.
Right, correct.
Laura. Go up here.
So no matter how good the picture looks, the answer
Down.
is a stent.
That's your
Mhm.
area.
Down.
Yeah.
Go up here. Well, you know, I don't know how good the picture looks, but let's see. I do have a lot of recoil there, as you can see. Down.
Lot of recall.
Down. Down.
That's better.
Yeah, let's balloon the ostium. Go up here.
That's
Down.
better. That's
Right
good.
there. High pressure. 20.
Yeah.
Down. Okay.
Let's take a picture.
Let me walk this out. Okay, DSA, please. Okay, inject.
Okay.
Thank you.
Okay. Ready?
Cindy, please. I guess we're learning how to use our pedal.
Sorry.
All right, let's do it again.
All right, ready?
I think Ray. I think Karthi has ADD. Let's take the pedal away from him. Very good. Hey, hurrah!
I like it.
All right, now give us the IVUS, please. Actually, you want to IVUS this or no?
No.
I don't think it's going to help us
It's
here.
not going to help us.
I don't think it's going to help us.
Karthik, can you hit the pedal again so we can have some lights?
Yep. So what?
Sorry, my fault.
Okay, so what's the point here? Let's get a big 30, 35, 210 balloon.
Yeah, you can look at the proximal segment, how dissected that AT is. So
Let's take a
definitely-
better picture here, Karthik. Inject now.
Yeah, I'm trying to open up the AT.
It's actually open. There you go.
That's good.
See the
That looks
proximal
really
segment?
nice.
Yeah.
But you have to stand that whole.
Yep, we understand. We're to do it. We'll stand it. 3035 210 first. So we're going to go up with this balloon into the AT, and then we're going to go ahead and then decide what the right thing to do is. Perineal's open and the AT's open. Look at that. That's beautiful. So we're going to have to put a stent in the mid AT there for sure, and then we're going to balloon the entire perineal. Ready?
Well, the question again really arises is how are you going to fix what's your strategy on the popliteal? You just
Well,
want to do it,
putting a supera.
DCB, and leave it.
I don't think so. To me at this stage, I'm just going to wait and see how it looks, and then take it from there. I think in this situation, the issue will be whether we give me a forceps, please. Whether we put a stent or not.
Give me a
I like
chloro-
Karthik's
chloroprep.
idea of using a DCB and just leaving it. Because with the supera, it looks like we're going to have to go with a 4.0 supera.
Chloroprep.
I'm not a big
2.
fan of the 4.0 supera. So we're just going to go with a DCB and leave it. So right now, the plan now is we're going to do a 3035 210 Medtronic balloon into the anterior tibial. Then we're going to balloon with a 2530 210 Medtronic balloon into the perineal. Then we're going to take a picture. At that stage, we're likely going to go ahead and put a supera into the not a supera, a coronary DES into the dorsalis
No problem.
pedis,
Take it.
unless it
Take
looks
it.
phenomenal.
You
So
wanna
we're going
help-
to stay
you wanna
live for
help?
15 more minutes, and let me see what's going on. Where's Dr. Guja leaving us?
No, I just need change of gloves.
So what did you do with your externalized wire? Did you pull it back, put it into
Nope,
a true lumen?
it's still outside, and we still got it
I think
actually
we should
clamped.
take it out and
Yeah.
just
We
I
said
think
this-
we should pull it back and
At
Yeah, I
this
think
stage, we
so.
just got it clamped. When Karthik comes back, I mean, I don't think it really matters. I mean, at this stage,
I mean, she's going to bleed, no?
no, now this is the right time to pull it back and
give
put
me a
it in
wet
the
one,
lumen.
guys. I mean, why are we putting things on dry wires, right? There you go. There you go.
He could take it out
No.
and rewire.
Yep, I will. When it comes to you, you can take it out.
Okay, I
Flora,
have the wire.
you got the wire, Flora?
I got wire.
There you go. Just stay there. Let me take it all the way down, and then you can take it out.
You have the fielder, right, PK?
Yeah, I'm holding the fielder, yeah. Okay, you can pull it back now if you want.
You have to pull the wire back. Well, can you go down with a little bit with the
A
balloon?
little more?
Yeah.
Okay.
So that you can definitely know for sure. Now you can pull back the wire and rewire it into the main vessel.
So
Pull it up,
we're
change
going to
gloves.
just pull this back.
Pull it out.
There you go.
Yeah, that's
All right, good. Let's go up. So we're going to balloon this.
Ray? Can you go balloon it? There. I'm
So
gonna hold
Karthik,
it.
while he's doing that, can you speak about this strategy now, which is what to
So what we are
save your
doing now,
DP?
so what, I'm sorry, so the pulling out the wire you're saying, Atul?
Yeah, I think this is an important part. This
So
is this
what
is
we
the right
what
time
we
to
did
do
just now is, because we got it
Show
from
me above.
above, we don't have to rewire or anything. All we did was pull back the wire. I'm just holding the access site, and the access site is healing. As long as the wire is there, she'll keep on bleeding. Especially now that we
10 is
opened the
down.
vessel, she's going to bleed even more. All we did was pull the wire back into the vessel. Now the wire is in the main vessel,
Above.
and
above.
it's almost sealed.
Above.
Right, and I guess another big point
Nine.
is because if the wire keeps
10.
externalized and we keep exchanging over the
Leave it up
wires,
at
you can
10.
cheese grade the vessel at the
Yes,
entry site, and you
yes.
don't want to cause
So
no
respirate.
trauma.
The
So as soon
Respirate,
as you're
mama,
done with your
respirate.
primary work, you just pull your
Respirate.
wire back, keep it in the lumen, and
Flora,
hold. You
save
just put
this,
a
guys.
pinky on it, and we are all good.
Just a moment.
Yes.
So she's feeling a lot of
Okay,
pain, which you
good.
would expect, because proximally we're definitely in the subintimal plane. You can see it there. Okay. Okay, down. No, hold on though. Yep, much better when it went down, Flora. Just want to make sure we get that ostium into the. Let's go up here, Ray. No, this won't hurt much. 5,
Give me
6, 7, 8, 9,
another,
10.
towel, bro.
10. 12.
Yeah, that segment between
14.
15 and 20 is what's your.
You
Yeah.
can see that area is right there. It's very
Yeah.
calcified. But I'm leaving this at 14 atmospheres with a 3.5. Okay, down. Okay. Walking into the SFA. I'm holding the AT. I'm holding the perineal wire. As it comes down.
It'll come down.
Fluoro. Great. Walk it back. Keep it in the now. When she has this much pain, keep it there. Let's DSA, guys. Cindy. In case you
Yeah.
perforate,
Yeah.
inject.
Uh-uh.
Very
One
good
second,
flow.
PK. We just have to.
I don't know why you guys are moving the.
No, we are not. She was moving, so
Really?
we want to hold it.
Okay, ready, Cindy?
Flora?
I know, at the wrong time.
Go ahead.
Cindy?
Yeah. Much better.
Much better.
You can use the same balloon for Peroni.
All right, give us a 20. No, I think we're going to use
Oh,
a
you
2025, 210 in the perineal now. Walk this out, Flora. And then once we do the perineal, Flora, please, and then
Yeah.
walk it out.
Flora? Oh. Sorry. I have it. Go.
So now what we're going to do is we're going to balloon the perineal.
I got it. Wire is out, PK?
Not yet, bro. Not yet. Now it's out. I got both.
Okay.
I got the wire.
Yeah. You got the wire?
Mm-hmm.
Okay. PK, take a foot shot once, you think?
No, I wouldn't yet. We know we're on the foot. It's fine. Let's not waste time. We're gonna go with the 2025, 210 into the perineal flora. Let me move the wire and the perineal down a little bit. Show me above. Here. I'm just gonna move that down.
That's probably a CTO again, right there. Yeah.
There you go. Okay.
We got it.
Good. Now we're gonna put the 2025 down. There you go.
I got it.
Wet.
You have the other wire,
Yep.
right?
I got the other wire pinned. Let's get a wet one.
Yeah, I am. I have the wet one and then.
So now we're gonna balloon this.
Vishal, any further thoughts? Atul, any further thoughts?
Yeah, I think after you balloon the perineal and you come back into the pop,
Down wire?
getting a microcatheter down there, taking a very nice picture, opening up a little higher mag, and seeing
Yeah.
exactly what we're dealing with at that bifurcation spot.
Other wire.
Yeah, I think that would be a
Yeah,
big
the wire.
point to keep
No,
make
not
sure
yet.
the vessel remains open.
But you know,
Other wire?
Vishal, I think the
I have
key
wire.
here,
Yeah.
the key here is, for the audience, it's not just because you get perineal access or pedal access, you're going to cross this lesion. You know, the bottom line is we worked together, we created a big plane, and then that plane helped us to cross. You know, so that's the whole point. Can you put me on coronary so I can see, please? And then mag up for me at the popliteal so I can see the balloon. So what you want to do is you want to be able to, you know, create those planes. If you don't create the planes, you're never ever going to be able to get through these lesions. You know, and now you know there's a 20, 25, 210. So I'm just going to take it all the way down, right? Probably that's probably enough.
Little more.
It's not going.
Oh, it's not going because there's a CTO there.
There's probably a CTO there.
Okay.
This is going all the way into the foot. So let's balloon this first.
Go ahead. Balloon it.
Slowly. And I think the principle there is very important for everybody at home. You know, you're trying from above and below. See, every dissection plane that we created, we basically did a wire cart, for lack of a better word. You know, that was a wire cart. You know, the wires created the planes in which we were able to then advance our catheters through.
Wow. Yeah,
so you can see here that now we're just going to balloon this slowly.
Go slow.
And she's going to feel this because it's a very, very small perineal, but it's a very important vessel. You know, and you can see Karthik is opening it up nicely. 6, 7, 8, 9, 10.
8, 9, 10.
Okay, well just,
Yeah.
okay,
10.
is Flora save that, guys?
Flora save.
And you know, I think the technique of balloon angioplasty is also very important right now. You want to leave this up for a little while, you know, so this way you get some good flow into this foot. You know, so you know, Atul, what do you think about our idea of staging this procedure? I think it worked out brilliantly. Can you talk a little bit about the anticoagulation you put her on after we just fixed the SFA? 10.
Yeah, so I mean, you know, she's 86. She has Afib with a high CHADS VASC, so we had to put her back on her apixaban. And then I usually do like to use dual antiplatelet for 4 weeks. We also put a covered stent. We waited a few days to start the apixaban, and I think that was the smartest thing we did. Let the hematoma in the thigh heal.
No, it's not going.
So in this case, with using drug-eluting stent down there, I would use DAPS for 4 weeks.
What's the wire?
Push the wire. Give me a coronary 2.0 balloon.
I think the same thing here. A short balloon should help you cross that stuff because of the pushability and get you down there.
So that we can all see
What's that, Vishal? We can barely hear you.
I'm saying the short balloon right there in the perineal might give you a little bit more length to go down.
Yeah, I'm going to go with a coronary 2.0 now.
Yeah, exactly. But I think I'll more focus on the AT as of now because, like you said, it's a direct inline flow to the ulcer. And since you already have established direct flow, my whole thing will be to keep that AD open by stenting it. And if the perineal distal CTO, we'll see.
So right now, Vishal, what Karthik is doing, we're walking out this long balloon, and we're going to open the 2.0 in the perineal before I take a picture. You know, and then we'll take a picture of the popliteal the way Atul said, and then we'll decide what we're going to do. And, you know, maybe we'll do that offline because I think it's already 9:30. I think we've demonstrated the important parts of this procedure.
Right.
But let's see how it goes. I mean, think about it. It's an hour and a half for this case so far, which is nothing. We literally, you know, with Karthik delaying us with access, we really just got started with this case at 8:30.
Totally agree.
So
I agree. Even the audience is saying that. So
audience is saying the same thing, and if they were like, if Vishal got access, we would have started.
That's true. I totally
Next
agree with that
time it'll
too.
be me and Karthik here. So we'll
I totally agree with that. I would actually love to do the moderation with Dr. Kukar. I have to connect back with him, so.
That's awesome. But I think, no, it's a great strategy of how you demonstrated to get in from both sides, both from retrograde and antegrade access, how to marry the wires and to work. And it's just the methodology, the thought process, I guess, is very important. And of course, patience, finding that true lumen to connect the dots and going from there. So great learning case. And rest all, like you said, here it's more technical of getting the balloon down and stenting. But I guess the takeaway home from this case is essentially the techniques of trying to cross the CTO and trying to connect the two dots.
Right here.
I think we got it, PK.
Okay, down.
That's it.
Okay, now I'm going to walk this back and take a DSA shot at this level. Go ahead. DSA picture. Let me just walk it out. Hold on.
So how do you follow these patients, Atul? Do you do ultrasound? Do you bring them back for another repeat angio? Or how do you work on these? Or
so I'll see you in the office
level?
in 1 week.
Yep.
I think we'll basically assess the wound as our because we have something on the surface to look at.
Right.
And then I just do an ultrasound. In this case, I may do it at 2 weeks. Normally, I do it at 4. And then follow her
Really
at 3
nice.
months, and it's all about the wound. If the wound's healing, I would probably stop doing
Now
ultrasounds.
popliteal.
Yeah.
So perineal looks very good. Now we're going to look a little higher. All right. Now we're going to concentrate on this area. AT looks really good.
Oh, she moved.
Yep. Now we got to take care of the pop. You see the AT is collapsing there? You see that?
Yeah.
So I think we should stent the AT now. And then give me a DCB. Give me a long 3.5 DES, please, to the AT. See the ostium is collapsing?
Yeah. it's
Yeah, no,
alright.
definitely you have to stent it, otherwise you're going to lose it. We have to salvage that AT for sure. So I think stenting is the best option in this patient. So
We're putting a 3.5 stent.
yeah,
Yep, 3.5. Actually, give me a distal as well.
3.538
Give me a 3.038 distal. Give me the forceps.
forceps.
Yeah, I'm thinking you may have to start closer to 20 and work your way
Yeah.
back.
Right,
Exactly.
at that calcified segment.
that's where when it changed the direction, that you have that hump. I think that's where it is. So
Yep.
Yeah.
No, 3.0
No,
first.
3.030.
3 first.
So I'm going to put 3.0 distal. Here's the wire.
start at like
3.5
21.
proximal. And then after this, we'll take a picture and then we decide. That popliteal looks like poo-poo, huh?
It's funny, I was actually going to say I think it looks pretty good compared to what you started with.
Oh, well, yeah.
And I agree with Karthik's. A drug balloon, I think, would do the popliteal well.
Somebody agrees with me. Thank you, Atul.
No, I guess the issue here is because, like PK rightly said, the Supera 4 won't give you much good results. We know that. If it was a good vessel,
Got it.
I would probably put a Supera because I want a straight
I got it.
inline flow
I
to
got
the
you.
AD,
That way.
and I don't want the popliteal to shut down and
Let's
cause the
just take
AT to
this
go down
out
because of the
and
pop.
stick it.
But here we are limited in our Supera and
So would
options.
anybody do a Zilver or would it, no, or would anybody do a, what is that other one called? The Alluvia? How about right there? Right there, Atul, right?
Yeah,
You wanna
21,
put 3
21 and a half. That's
21,
fine.
yeah, 22, perfect.
I'll pull back then. Right there?
Right there.
Yeah, right there.
Okay.
Yeah.
More than that, PK. Because
No.
you're going to fall short of 38 on the top,
I-
right?
Well, let's
So
start.
you'll end up putting 3 stents. If you're putting 3 stents, you might as well go down more. So
Let's pull
a
back
little
then.
bit. Yeah,
Fine.
pull back.
Right
That's
there?
Good. That's okay.
Okay, let's go.
Mid 80.
Give me a 3.538.
Well, that's a lot of collapse.
And you can see that calcium segment, that's where our segment didn't expand all the
20.
way, so stent would give us a good
Yeah.
option. Even here you can see a little bit of waste
Cool.
right there.
14.
So Karthik is going to 20 atmospheres here to expand it nicely.
It's very tight.
Okay, good.
Pull back.
Go up again one more time, just to make sure.
Pull back and go up again. Yeah.
Excellent.
So you're going to fall a little bit short, probably. Right, PK?
Done. Okay. 3.538. Okay. Artie, were there surgical considerations for her or because of the age?
So the discussion was had, but it was a very, very quick decision based on 86 years old, and her functional status is also not so great, which is why I think the ulcer was our main driving force. So
Sure.
we really want to give this a good shot, and
Floor.
I don't think surgery was going to be an option even if this failed. It may have just been more wound
Conservative.
care and amputation of the toe if necessary.
Okay. Flora? I need to come back a little.
X-ray.
Is this a balloon or a stent?
It's a stent.
How come
Yeah.
I don't see the stent?
I know, I don't see it too, but it's a stent.
Let me come back a little bit. Flora? I think that's better. Let's go up here. We'll leave a little gap.
Okay, there's a gap between.
It's okay, a little gap.
Puff a little bit.
You want
I
to take a
think-
puff of the ostium?
Little gap's a little healthy, right?
You want to make sure, can you take a puff of the ostium just to make sure?
I think
At
you're
least we're
too
one
much
way or
into
the
the
other.
pop, PK.
Okay, go forward a little.
So
Yep.
you're too much into the pop.
No.
You can go down a little bit. That's a
Okay,
good
go
spot.
up there.
Even a little bit lower, PK.
It's all right. Let's go up. It's good. We worry about the gap and all that. This does not look like a stent.
I know, but it's a.
Hopefully,
is
unless
convinced.
you strip the stent somewhere on the way.
I saw it as a 3538. 3538. What kind of stent is this?
Go up.
1 second. It doesn't look like a
It
stent.
doesn't.
It doesn't look like a stent though.
It's a balloon.
It's a balloon.
It's a balloon.
Yeah.
I don't know. We'll see.
It's a
It's a
balloon.
balloon, guys.
3538 Zions.
3538 Xines, please.
Why did you guys give me a balloon?
I've never seen a 3538 balloon.
There is no 3538.
I have never seen a 3538 balloon.
That's what I said. There is no 3538 balloon.
It is a 3538. See it?
No,
No, I
but
agree.
you want to? Is it a Zion? You want to make sure the stent is not stripped?
See, it's 3538.
I had no problem going down. Let me see.
No, I mean if you think that's a
Let's
really
sca-
stent
Let's
shaft.
scan up.
Yeah, I mean.
Show above. There was definitely no stent. When I went in, I didn't see a
Above
stent on the balloon.
Oh, okay. So then. But
That's
there
what
is-
I think this is Abbott way of meeting their number.
I didn't know that there was a 3538.
I've never seen a 3538 balloon.
I'm not joking. There was no stent in this body
No.
when I went in.
No,
Our Karthik scanned the entire SFA and the sheath. Go up. I'm telling you, I looked at it. That's why I didn't see it.
So they shortchanged us.
See? There's nothing. Nothing. I'm telling you, Liz, I looked at it when I went in. I thought these guys were fooling with me just
That's
to
what I
make
felt.
fun of my eyes.
But,
Okay.
The texture is
it's strange, but it's very strange because there's
Was it just the first stent you put in and you just took the balloon back in?
That,
No, no,
it
no.
was a fresh balloon.
Okay,
because
fine.
it was it's written 3538.
Yeah, so it's a stent, but there is no stent on it.
There,
It's
so
very
basically, I got a stent from Abbott without a stent on it.
What's this in the shelf? This one. Yeah, in the
Oh, it's strange.
this is no cross.
Now make sure, please, there's a stent on this one.
Unless it's stripped off when we were pulling it out.
I'm telling you, when I touched the balloon, there was a balloon. I said to myself, okay, this is a joke. They want to get me back.
No, it's 3538.
Probably Ray used his power and
Yeah.
stripped it. Maybe it's Ray's
No,
fault.
Ray is right. They have a packet here. They have a packet here with a stent on it. It's
At least I didn't say
3538 Zions.
Liz's fault.
No, it's
Maybe Sandeep was touching it.
Maybe it's Singla who's playing all these games from outside. All right, hopefully we'll get a stent now.
Karthik, how does the foot look?
Huh?
The DP axis side.
It's healed. There's no blood.
Great.
Yeah, see, now it looks like a
Huh?
stent.
What happened?
Okay, let's go up.
Are we missing
Now
the
does
ostium?
everybody agree there's a stent on this balloon?
Yeah, but we're right at the ostium, right? Looks like.
What happened? It fell off there?
All good.
Go up.
All good.
Huh?
All good. All good.
Huh?
We are looking at it.
Yeah, it fell off.
It fell off. It fell off.
It fell off. Go
It's
up.
the fellow's fault.
Yeah. My fault.
It fell off when they were pulling it out. I think it stripped off from the balloon.
That's what I'm saying. Ray uses all his power.
Pull back a little bit, PK.
You want to pull back just to... Yeah.
There you go.
Go up.
Yeah.
PK
Done,
too
yeah.
much.
Another 3 pounds.
Go up, please.
Yeah.
Okay.
There you go. Down. Go up again. Down.
You want to go down a little bit?
Go up.
Nice.
Down.
Like it. You want to take a picture?
If it fell off, it has to be in the wire.
No, it's outside the body.
Oh, okay.
It fell off when they were taking the stent out. In the yellow cover.
Mm-hmm.
It's in the yellow cover.
Okay, go ahead, work it out. Right, DSA above,
DSA coming.
fluoro,
DSA.
Ready?
fluoro. Okay, a little higher. Okay, this is good. DSA, inject.
Very nice. See the stent, PK? A little
Yep.
bit too much, no? Little
That's
bit
good,
too
looks
much
very
into the
nice though.
peroneal, no?
Huh?
Little bit too much into the TP trunk.
That's okay.
No, it's good.
Well, it's perfect.
It's covering the
All
ostium.
right, now give me a 2530 210 for the perineal.
3530 210.
2530 210.
Tapered balloon.
Here you go, Chief. Here's this.
Yeah, very nice.
This
Vijay,
wire?
for the 80. I got it.
Kissing.
So then, and then give me a Stellarex balloon, or you want to go with an M? Give me a. So what is your take, Vishal, and last comments before we get offline on this mortality with drug-coated therapy?
I mean, that's a very interesting proposition with these meta-analysis coming one after the other, one in JAMA, one in JAC, and then this Viva consensus, I think, which is coming up in a week or so. So it has to be looked into. I mean, it all depends on, they had a bigger meta-analysis published recently which showed actually no mortality from the PA, from the paclitaxel itself as compared to the
Let's
other
load.
therapy arm. So
No,
I
was
think that's one
going to
thing
the food
probably
picture
needs to
before.
be
No, don't
further
worry about that.
looked
That's fine,
into,
that's fine.
and I mean, decide. I mean, it's up in the air. It's still needs to be figured out what's the truth and what's the reality.
So
we'll see.
would this a problem now, Atul, prevent you from using a drug-coated therapy in this patient?
No, I don't think so. I think I agree with Vishal. These are meta-analysis done. It just, what it does is it opens our eyes to say we should be thinking forward, and we should
Wire?
look into it, but I don't think we should stop doing what
Real?
we've known for some time to be the most effective therapy we have available today.
Right.
Let the wire go a little, please.
Oh, watch it. 1 second.
Let go. I'm not even going to go there anyway.
Yeah, I know. That's why I'm not.
Oh, that's good.
Let's pull the wire back. Let's see.
1 second, PK. PK, watch the wire. You want me to wire it?
Yeah, try to wire it.
I think just leave it right there. Just
I just leave it. I just go up with the
I would
balloon
just
here.
leave it right there. That's it. Yeah, just leave
There
it.
you go.
There you go.
Okay, let's
Good.
go up slowly. So this is a little bit bigger size balloon here, 2.5, but I want to increase as much blood flow to the foot as I can. Okay, negative. Go up.
Is it? No.
Respira con su boca, mamma. Respira. Respirei, respirei. Respira. Lo siento, mamma. Lo siento. Lo siento. Lo siento. Okay, no más. Now pull back the balloon across
back.
the perineal. Okay, a little more. A little more. Okay, go up now. Now I think we need to do a couple of minutes inflation here before we do the DCB. What DCB would you guys use? And how do you make that decision?
Although, I guess depends on what you're in the mood for. No, I mean,
I think you can go either way. I mean, you can take a Lutonix. You know, the length is short. Both balloons come in the shorter length. You can go with the Lutonix. You can go with the Admiral. I don't think it's really going to make such a big difference here.
I mean, yeah, Stellarex or Impact or whatever. I guess you want to
Down?
do.
Show me
I
down
mean, you
this
can.
one.
People still argue about the data coming from one versus the other, and
Okay, let's just keep it here
there are
as we take a
contentions,
picture.
but I
Walk this
think
into the SFA.
all of them work pretty much equivalently. So we'll see.
So for the audience at home, since she's having so much pain, what I do is, you know, we could always perf with this. So what I do is leave the balloon in the SFA and have Dr. Guja inject. This way, if we have to balloon tamponade on, we balloon tamponade on. No, a little higher.
That's where she had
No.
the pain, no? PK?
Okay.
Probably
Just-
that's
yeah,
where the
let's go, let's
oversize
go.
the
Yep.
balloon.
Yeah, we
No
can take
muevo,
both
mama.
levels.
No mueva.
No contrast. 1 second, PK. Sorry.
No more. Can we have some contrast, please?
No. Ready?
Okay, inject. Very nice.
Beautiful.
So you see ballooning that perineal really helped the blood flow. Show me above now.
Very nice. Beautiful.
Okay. So now I'm just gonna let them walk this out. I think we're gonna call it. So I want to tell the audience what we're gonna do. So it's 9:45. I think we went a little bit over, but you know I think so that we got through both the AT and the perineal. We've established straight line flow to the foot. Now myself and Dr. Guja, along with Dr. Kapoor and Dr. Kupkar, what we're going to do is we're going to go ahead and balloon the on both the wires. We're going to go ahead and balloon the popliteal with a drug-coated balloon. Now, if that popliteal artery dissects, then we're going to go ahead and put a drug-coated stent if we have to. But you know, at this stage, I think this is a very good demonstration of how to cross these lesions. Dr. Sardar did a fantastic job with his presentation. He actually had a whole bunch of topics on drug-coated stenting and all that, which we didn't even get to, because I thought the technical aspects of this case was very, very important to discuss. We'll definitely do that presentation in the next live case before we get to the next live case, which I think will also add to the educational value. But again, on behalf of Dr. Guja, myself, Dr. Sardar, Dr. Ray Lascano, obviously Damien, as well as Liz and Marichu, who just woke up, I'd like to say thank you again, and we'll see you guys next month. Thank you again.
Thank you, PK and Karthik, for such an excellent case. Thank you, viewers, for joining us. We'll see you next month on March 27th, 8 o'clock Eastern Standard Time, here from Mount Sinai. Till then, for any questions, comments, and viewing this case, you can go to our website, ccslifecases.org, and click onto the peripheral arterial section. Thank you again, and have a great week ahead. Thanks.
Thanks.